thank you. I appreciate being here. I was actually quite a trip in this morning, and I appreciate Maggie's help guiding me by phone here ultimately. Last minute, just pulled in. I'm very open to questions, comments at any point. I'm not anxious about covering the slides or the material, and so feel free to jump in at any time. In October I turned 50, and I've come to the realization to this point I have yet to have a really good independent original idea myself, and I don't expect that to change, but I have been fortunate and able to recognize good ideas from others, and over the course of teaching medical students, nursing students, residents, and faculty, I've accumulated I think some of the best ideas that I've seen in quality improvement, health professions education, as well as in adult learning and related education fields. And I thought I'd share some of those ideas with you as part of a conversation, I hope, about how we can improve continuing education. So there you go. I don't have any conflicts of interest, and I won't be discussing medications. I'm again sharing some what I think are key insights from quality improvement, adult learning and health professions education, and I hope to talk with you a little bit about them as a way of improving the effectiveness of using continuing education for the purpose of changing clinician behavior and improving patient outcomes. Just a few questions, and we'll kind of end close to the end on this slide, but some ideas or some questions I'd ask you, I'll give you maybe a minute to think about them. These are things that I think are important and relevant, and I hope to begin to answer them, or at least partially answer them over the course of the next 45 minutes or so. But I'll give you a chance to read those. So just a comment on each, and we're going to start off with this first, some content about this first question. I've been thinking a lot about just these two immediate stakeholders, CME providers, those people who are leading, developing, designing efforts to change behavior, and then participants, people like us that are often participating in continuing education programs. And I'm going to use continuing education, generally speaking, rather than CME, just it's a little more interprofessional, but CME is obviously included in that. But I've been thinking about these two stakeholders and the relationship of them to one another with respect to important outcomes. I've been involved in quality improvement and in continuing medical education, and only until recently did I begin to realize that people had really different opinions and maybe not even agreement that those two things serve the same purpose. I see them as a continuum, with continuing education serving quality improvement interests, which in turn are serving patient care interests. But I've had colleagues, reasonable colleagues, at least some, disagree with me and say, no, CME is one thing and quality improvement is something else. And maybe we could talk a little bit about that. And the last is, all of us have some expertise. And if we're experts in something, as I do a lot of work increasingly in adult learning, the notion that do experts learn differently ultimately when exposed to new material in their area of expertise? Are they more adept or not than generally other folks, other adults, or any of us in areas in which we don't have expertise? Do we learn differently if we're experts and we're exposed to something new in our area of expertise, or is it the same? So this, you all may recognize this. Paul Mazmanian and Dave Davis published a literature review in 2002 on the state of the art with respect to continuing medical education. What makes it effective? And as you may recall, the major point of the article, and the point that I actually thought most about until recently, was this notion that there are some principles and practices that make continuing education more effective. Multifaceted interventions, needs-based activities, interaction, those kinds of principles and practices. But one of the things that they mention, and there's a table on the second page of this article that lays out, it says, CME participants, CME providers, and talks about the roles and responsibility of those two groups. And what I've begun, and again, I do a lot of teaching in the undergraduate sphere as well in the last 7 years, and I've begun to see parallels that predict what I think we often see in continuing education, where, starting with continuing education providers, where we ultimately develop activities, and often those activities are predominantly passive, predominantly lecture-based or reading-based. And if there's some interaction, it's typically not the majority of the time together. The other thing I've noticed is that, if you all had training like I did, we have participants coming to these generally passive activities, and they're not necessarily coming with a specific question in mind or idea or goal. They're not coming to the session. This is a sweeping generalization, forgive me, but generally speaking, I don't see people coming and saying, I'm here because of this reason, and I've interviewed people as part of a study. I'm here today specifically for reason X. I've struggled with this case and I have a question. They're not coming with a very specific idea. They may not even know who's talking or about what. In a lot of our grand rounds programs, you'll hear people come in and say, who's here today? What are they talking about? Where are they from? So they're not coming. And so when we have activities that are not designed with, interaction and other principles in mind, and we have people attending that are not prepared and not coming in an informed, activated way, we can predict that those activities will not be as effective as they could be if either group was doing something differently. So both groups have a responsibility, and actually the ideal would be if both groups were doing that, right? If we had, I'll borrow the language from the chronic care model, if we had informed, activated consumers of continuing education coming and making choices, parsimonious choices about what activities they're going to attend and what they're not and why they're going, and picking and choosing. And if we had CME providers that were doing if we were doing a much more rigorous job of needs assessments based on population parameters, and we'll go through some of these important educational outcomes, we really could be using CME and CE to transform care. But right now, it's hit or miss on both, and rarely are both happening at the same time. And I think for me, I remembered back at this, and I think this was one of the key aspects of this article that at least I missed the first time. I'm going to jump to quality improvement, and one of the best, if this leash will allow me here, one of the best, I'm a slow reader, so I pick and choose what I read, but W. Edwards Deming. There's any book you ever want to read about quality improvement, it's Deming's book on the new economics. And it's actually at the end, the last slide gives recommended readings. But Deming is a wonderful writer, and I think he provides a lens for us, at least a lens for me. This was the most compelling author for me in terms of understanding quality improvement and its relationship to education. And he offers, and the next slide will describe his leadership paradigm, but one of the neat things of Deming, he talks about leaders, and leaders, informal or formal, right? And one of the nicest definitions of leadership is simply inspiring others to improve the work that they do, inspiring others. And so Deming says leaders, educational leaders and clinical leaders have three sources of power. Authority is the, authority of office, right? They're the things that we can do because we say so. We sometimes over-rely on that. And some of the worst leaders, you'll say they're very authoritarian. They just, they make decisions without input, and generally, they're the only reason they're followed is because you have to, at least at the moment, right? But Deming says we should develop the expertise in the other two areas and rarely use our authority. So he says we need to have knowledge about systems and how they influence behavior of individuals. And if we're able to explain for people a problem in simple terms, not oversimplistic, but simple terms, and convince them of the plan to move forward, of course with buy-in, and we're able to understand, and I'll go through his 4 components of his paradigm, we can be incredibly convincing. So knowledge is acquirable, right? Same with persuasive abilities. So Deming says, it's great to have charisma. It can be developed. We all have some more or less, but that can be developed. But the more knowledgeable we are about understanding complex systems, the more passionate we can be in convincing and helping others to begin to think differently about the work they do and how we use education to change the work that we do. So this is a great book. It's actually, I'm a fantastically slow reader, and I can read this in a night. And I've probably read it 15 times, and actually, part of the reason I like it is I used to teach a quality improvement course about 15 years ago, and my daughter came with me to one of the sessions, and she drew pictures in the back of my book. So every time I read it, I look, she's got pictures throughout the whole book. But one of the reasons, but that's not the only reason I like it. It's a good reason, though. So I mentioned to you, Deming offers us this leadership paradigm. And for me, I use this in education. It's a quality improvement leadership paradigm. But for me, this helps me understand how to think about education and how to use it differently. And without it, we can certainly gravitate towards the evidence and principles, practices that we know work. But this paradigm, for me at least, helps me organize my whole thinking about how education fits in to a larger whole. Without too many details, these are these 4 interrelated components of his system of profound knowledge, which is his framework or paradigm for leaders. And I'll mention a couple. I'll say a little bit about each of these components. So what you see here on the slide, obviously, is a typical flow diagram of any system, right? Could be manufacturing, could be healthcare, could be business, could be anywhere, right? And so Deming says what leaders have to realize is that people work in systems, right? And we can't take them out of that system. Everything is context-based. The reason that's important, in a subsequent slide, we'll show his statistics on this, but essentially, anytime we're using education, we have to think about the context in which people are working. And there's a lot written about this, and I'll comment on it. But Deming says that we have to first and foremost realize, particularly when errors happen or where there's quality problems, you think first about the system in which people are operating, because systems obviously explain largely why we behave the way we do, for the most part. So he says this systems perspective is critical, and people need to understand where they fall in a system and what their role is, and that there's people that serve them, and they in turn have customers too. And ultimately, a system can only have one primary aim. And in healthcare, that's pretty easy. It's high-value patient care, high-quality patient care. You can, the IOM, STEEP acronym works: safe, timely, effective, efficient, equitable, patient-centered. However you want to define value-based care. But essentially, we're all working towards that goal. So Deming says, anytime we intervene in a complex system, we've got to think, what's the primary aim? And how does this intervention, this oversimplistic intervention in a complex system, relate to that aim? Is it consistent? Is it inconsistent? Because we can do, as you all know, we can do more harm with our interventions, however well-intentioned, than good often, right? The wrong intervention in a complex system causes all kinds of problems. It happens all the time. Good intentions, reflexive action, often driven by regulation or accreditation sometimes, which is sad that happens. But nonetheless, we want to use our interventions, education or otherwise, very thoughtfully. So again, more about knowledge. So Deming says, leaders should be knowledgeable. Well, for Deming, he always talks about the importance of variation, and that interventions should seek to decrease variation, right? It should shift performance in a positive direction. It should narrow, make systems more predictable, right? And he's talking about unintended variation, right? He's not talking about when guidelines say X and patient has an allergy or the patient's preference is otherwise, or he's not talking about when we consciously say, well, the best thing to do is X, but given the circumstance we can't do it, so we do Y. He's talking about our making sure we do X, or at least we think about it first and foremost. And what's true in healthcare is we know, despite our best efforts, we have good, caring, bright people go into nursing, medicine, pharmacy, social work, and despite our best efforts, and we are functioning in a system that, on average, and this is an older RAND study, but every time we look at it, about 55% of the time, patients are receiving needed services from us, right? These are people with access, people who come to us. These are evidence-based areas. RAND looked at 30 conditions, 439 quality indicators, and they say no matter how you spin it, there's variation, there's a range, and gee whiz, it's in the 50s. Problem. So Deming says we need to understand variation and its causes and intervene in ways to decrease variation, unintended variation. Where to focus? Again, part of Deming's theory of knowledge. We need to know where to focus. So Deming says, show me a problem in a system, or show me a problem with variation. And he says 96% of the time it's a systems issue. It's not that there's a bad person or a person who's choosing to do the wrong thing or a person who is doing something illegal, unethical. That happens, right? I can tell you as a psychiatrist, there's a certain percentage of people, 1, 2, 3% sociopaths that are going to do things that, aren't right. But generally speaking, when you see a problem in a system, Deming says, look at the system itself, because it explains probably why people are behaving the way they do. So when and this often happens, leaders will say, there's a problem, we need an educational intervention to fix it, we need to tell people what they need to do differently. Well, often people know what they need to do, right? They're knowledgeable. It's not a problem with knowledge. It's a problem with performance, right? It's a contextual issue, right? And so Deming says we got to think first about systems, and then when you look at the system, if there's an outlier, that's a separate situation. But generally speaking, most problems in healthcare are matters of system issues. So education has a very important but limited role in improving quality. In education, when we're in a role, people ask us to develop a program, teach a course, whatever it may be, the first thing we think about is content, right? What do you want me to present on? What do you want me to say? What do people need to know? And we spend all our time, or most of our time, on content. But there's two other areas that actually deserve much more thought than we give them. Certainly more thought than I've given them historically. And one is process, right? How we go about whatever the content is, right? And let's say it's needs-based and it's population-driven and we know what the content is if it's necessary. How we go about delivering it is critical, right? So the process of delivering it. There's a really nice, and I'll show you the reference at the end, a nice way of thinking about any time you're using education, it should have at least three components. A predisposing component, like preparing people mentally for the activity. Either they're reflecting on performance data or changes in a guideline or whatever, or a challenging case. So a predisposing activity, preparing people mentally for the activity. Then in the activity itself, which hopefully is interactive. And then following up later a post-activity, which is reinforcing, right, in some way. And it could be a quality improvement intervention. It could be a clinician reminder, right? Could be provision of performance measurement and feedback data at some later time. So predisposed people, interactive activity, and then a post-activity that's reinforcing. So that's process. And the third, which John Arent is an author that writes a lot about context. And increasingly, when we see some really well-done systematic reviews and meta-analyses, often you'll see that the take-home point is, well, these are the factors that appear to explain 5-10% of the effect that we're seeing, but we're really not sure what explains the rest of the variation we get across studies. The rest of that stuff is context. At least that's the belief, and I certainly believe it. So these are all the variables other than the intervention itself. And we need to be thinking about the context of the educational activity itself, but then more importantly, where people are working. Again, this systems issue. So anytime we're using education, I try to think about content, process, and context, and do the best I can to understand them and use them to leverage, education more effectively. I'll just pause there for comments, questions. Yes, please.
You said 96% system and 4% individuals.
Yeah.
I'm a psychiatrist.
Oh, nice. Yeah.
Non-compliance, one of the biggest problems
Yes.
in medicine, I would feel, is much more patient-centered than system-centered. So the largest problem in medicine, one of them, non-compliance, non-adherence, is so importantly psychologically driven. Either one doesn't understand or one doesn't believe it.
Yeah.
And so I'm not comfortable with your 4% and your 96%.
Yeah. That's a fair comment, and I think I would agree with you that patient non-adherence is a factor, and it explains some of the performance gap, right? I don't know how much it is. It could be 10%, could be 30%, could be 50%, and it probably varies by patient population, condition, and a bunch of other factors. What I will say is that, and there's aspects of it we can do something about, right? We often can't change people's insurance status. We can't often solve transportation problems, but the whole literature on how we can do a better job with patient-centered care, I think, helps us to make some inroads on that and address some of the things. Like, when I used to be in the Department of Psychiatry doing consults in the hospital, one of the common requests for a psychiatry consult was a question about patient competence. A patient was refusing a major procedure, a life-saving procedure, wanting to go home against medical advice, and they say, oh, they're not competent, can you come and declare them incompetent so we can do whatever we want? And we would see the patient, and sometimes they weren't competent, no two ways about it. But often they were, and I'd say, why are you refusing, this AAA repair? And they say, well, I don't want major surgery. I'm like, well, I don't blame you. But do you realize that if you don't get that repair, there's X% of a chance that will rupture when you're at home or somewhere else? And like, oh, and if that ruptures, then there's an excellent chance you won't make it back here. And oh, well, I'll take the repair. I mean, often we don't always do a very good job of patient education. And so that's an issue. So I think that I would agree with you, and I think there's an aspect of it that from a system standpoint, we're often not reimbursed for education, especially in primary care, right? We have, 12, 15 minutes, maybe 7 minutes, depending on where you are with patients. We've got a long list of chronic problems, and we're expected to do education, as part of that. And so that's a systems issue, right? It's a reimbursement issue. How do we go about using our teams more effectively? Let's not rely on the primary care provider to do everything. There's all kinds of ideas about how, but I think it is an issue. I just would think that it's something we could address, and it's part of a larger systems problem. It's a good, yeah.
I'll come back
Yeah.
to 3 points when we discuss the 3 issues.
Okay, the reflective questions. All right, thank you. So these are the things that, we know, generally speaking, from the literature, when educational interventions work, these are typically the reasons that have been demonstrated why they work, right? These increase the likelihood that educational interventions work. So when we do a needs assessment, right? So obviously, then people, we're covering something that's relevant to them, that they recognize is important, something common, something serious, something that they're experiencing frustration with, right? Needs assessments help us do something relevant. When interventions are intensive, we know that often one-time kinds of things aren't enough, right? Because again, change is incremental usually, and people need to come back to it over. And I'll review some of the latest thinking on adult learning and why that's the case. But it's certainly accurate to say that more intensive interventions obviously are more likely to change behavior. When we sequence things logically, if we have a multifaceted intervention, what comes when is critical. And this is the problem with conferences in general, right? You go to a 3-day conference and you get all kinds of stuff at once, and maybe collectively everything's addressed, but not in a way that allows us to process it and think it through. And while learning is not a linear process, it's messier than a flow diagram would suggest. There is something to be said about the steps that need to happen. So if there's a knowledge deficit, we should address it before we measure and think about competence. If competence is an issue, we shouldn't expect changes in clinician performance. If there's a problem with clinician performance, we don't necessarily know what to offer patients, we shouldn't be measuring or expect to see changes in patient outcomes. So there's some logic to the design of educational or quality improvement interventions. We know that interventions need to be engaging, right? Interaction is not so much a social interaction, right? Although that can be a vehicle for the type of engagement that adult learning experts talk about. But engaging is, getting people to think deeply about something in their own heads. That's what interaction is. Their inner world is kind of interacting with the curriculum and their colleagues, and that's the kind of interaction we want to see happen. Because if it's not that type of deep thinking, there's no chance it'll have any impact. And it's interesting when you look at studies, brain studies of people doing activities. Often we can do things, we can write things, we can read, we can listen, and part of our brain is obviously engaged, but not the part that encodes memory or where memory is stored. And so we can do all kinds of things. And I deal with the undergrads all the time when they're struggling, and I tell them, hey, help me understand how you study. And they'll say, well, I went over my notes 10 times. I stayed 20 hours. I went over my notes over and over. And what adult learning experts will say, well, that's actually an illusion fallacy where things look familiar to them, right? They go over it and over it, and everything looks familiar. And at the moment, they get it. But they're not thinking deeply about it, not challenging themselves, they're not applying it. So later, when they go to access that information, they realize, well, I kind of know this is what the question's about, but I really can't explain or apply this, right? And so, we really need to get people, thinking deeply, and so the activities themselves, need to leverage that at some point. And finally, one of the, really simple and effective strategies is commitment to change. Asking people at the end of an activity what they personally plan to do differently. You're not holding them accountable, there's no consequence. You're asking them to commit to doing something differently as a result of the activity. Simply doing that can increase the likelihood that people will follow through. And whether it's, healthcare providers are honorable people and they make a promise even if it's, there's no consequence to breaking it, they'll still follow it, or it gets them to think about the material in a different way, in another way that reinforces it. However it works, it does work, and those are things that we should consider. Comments about these? Things that are missing? I'm sure there are. Always a rule of thumb, which is painful actually, is, and this, particularly with undergrads, is when you ask a question, how long do you wait? And the advice is 10 seconds, which is a really long time, and you'll appreciate this. 10 seconds used to feel like a long time. When I was in practice, one of the techniques that I tried, actually it was in residency, I never tried it again, but it was called time-limited psychotherapy, and we had to choose a patient, only meet with them 10 times, and only respond to their initiation of conversation. The psychiatrist couldn't initiate conversation. You had to just wait for them to say something, you could respond to it, but only if they initiated it. And I remember there was one gentleman, and he did not like it one bit. And he was waiting, and I was waiting, and 41 minutes. We sat there and looked at each other in a quiet room. And so now 10 seconds is nothing when I think every time but he did give in, actually. I was grateful. At any rate, I guess it's not important right now. What's that? Yeah, it might have been something. I'll take anything, yeah. A mumble, a snore, anything. Oh, yeah, please.
How is that changing now with different modalities of obtaining information?
Yeah. Yeah, go ahead. You were going to.
Initially, human beings learn by looking and listening,
Yeah.
maybe speaking and measuring. But now it's beyond reading from a piece of paper and maybe marking up with a highlighter to glancing and flickering the screen.
Yeah.
How much of that is actually eroding what we know?
Yeah, it's a good question, and it generates a lot of controversy. Actually, this book here, which is there's a New York Times editor who has been studying neuroscience or following neuroscience, and for 10 years, this is one of the references at the end. Benedict Carey writes a lot about this, and he he addresses the concern, particularly, and I've got a, my older daughter is a senior in high school, and I see her and her friends, and I have conversations about how they use social media, how they use their cell phones, and how that interrupts their study, and all these kinds, and the concerns that we often have about, why don't you turn that thing off, focus for an hour and then turn it on, and then, and his point actually is he's much less concerned, and he sees it that there's a value of interrupting learning, particularly if it creates some tension. If we're making progress in something and we're interrupted, that's irritating, right? I mean, I get fantastically irritated, right? But ultimately, in the long run, it actually increases the likelihood that you remember it because it forces you to go back, think where you were, re-engage what was stored, and then work with it again. Again, there's some point, though, the interruptions are so frequent, it would interfere with learning. But generally speaking, some interruptions. But I think you're also getting to the issue of how younger people access information. I've had undergrads in a class say, you give us all these reading assignments, you don't understand, we don't read anymore. And I'm like, well, I'm sorry, I disagree with you. If you're not reading, you should be. But they believe that, directed reading, looking things up, is certainly a better use of their time in the short run, no two ways about it. But I try to talk with them about the value of doing different things to access information. Even if I'm strongly a visual learner, so I prefer to read something. I wouldn't be listening to me. I'd be looking at that if that was up. And I say to them, regardless of your learning preferences, your learning preference, you can learn in different ways, and actually you should. And there's a lot of literature now on context-dependent learning, where if you mix up where you study or where you do your learning, your brain uses a lot of the cues around. So if, it used to be find a quiet area and study there consistently and make sure whatever, the environment was at the time you're studying is the same as the exam room, all that stuff. And the reality now they're saying is vary your study location. Unless you're very interruptible, have there be some noise. Try different places. And all those contextual cues give you inroads into that information. And so I made me feel a little more hopeful about what I see as, and when I teach particularly undergrads or even grad students now, they're multitasking. And I worry about that, but it may not be a problem ultimately. So it's a good point, but I think I think to some degree it's an issue, but it may not be as big an issue as at least I was originally concerned.
Memory's a creative process. So the issue here, I guess, is if you had a way of creating memories in a certain context, and suddenly it's disrupted by technologies. I mean, I feel like I'm operating a backhoe whenever I think of history of physical on a computer.
Yeah.
I'm just operating heavy machinery.
Yeah.
And it's the opposite of holding a pencil and paper.
Yeah. And actually in that circumstance, say, well, you're struggling with the technology, and maybe that's the best way to learn it, but you're making the point that it's competing with this higher priority, and so I am concerned about the ever-changing technology, because a lot of the research I do is in primary care, and every time, people say, I was just getting comfortable with this EHR, and now it's being updated, or we're changing, and I am concerned about the implications of that, because the goal is not for us to be more and more comfortable with technology. The goal is to provide better care, and we were hoping that technology would facilitate that. And I'm not dismissing some value of technology, but I appreciate that is a relevant issue to think about from a leadership standpoint about how many changes at once and prioritizing, because again, we're trying to help people function in a certain way. So it's an excellent point. This is a wonderful article by Moore, Green, and Gallus that came out in 2009. And in this article, it's really about planning and assessment of educational activities, continuing education activities specifically. And in this article, they lay out this expanded outcomes framework. And I'll mention those things. The central actual theme of the article, the central point of the article, though, is they say that we should start with the outcomes and goals in mind and develop an activity that has the prospect of changing important outcomes. And so what they say is that historically, you'll recognize on the left side, these are educational outcomes that are still important. No ands, ifs, or buts about it. These are outcomes that are important, and they're specific to the individual, right? But what they're saying is that there's other educational outcomes that our traditional continuing education activities don't address. And what they say is, rather than start on the left, with participation, attendance, satisfaction, knowledge, competence, and get as high as you can, they're saying start at the community health status level, which they call level 7. And they say, look for performance gaps there. When you narrow down the potential topics or conditions you want to work on, then look at your own patient population. Of those, which are areas that have opportunities for improvement? You narrow it. Then you say, okay, what are the evidence-based practices that are linked to the outcomes we're looking at? Where are there opportunities for these processes of care? Where are we not performing as well as we could? Then you say, okay, are clinicians competent in an educational setting with those things? Are there gaps there? So you basically work your way down to the point where there's no gaps, no performance gaps. Then you plan a program that works its way up. And the program would be necessarily longitudinal, multifaceted, and carefully sequenced. But you bring people along a continuum that has the prospect of changing as high a level as you can. Sometimes we can't, or we're unable to address the highest level. You address as high as you can, but you prioritize. And so I really like this article because it reminds us ultimately of where we want to be. We certainly want to be smarter, right? But smarter in the service of our role, which you were referring to, of providing high-value patient care in ways ultimately that serve our patients or the broader community, some of whom we're serving, some of whom we're not. So they recommend that we think and start at the highest, look for performance gaps, and plan accordingly. This look familiar, or where do you see the programs that you're involved with or participate in focus at? Are there certain places where we're emphasizing or places we're not?
Interrelated. You can't go either forward or backwards.
Yeah.
So I'm a pediatric cardiologist, and what we've seen across the nation is that there are certain areas in the nation where the fetal diagnosis of congenital heart disease, this is the year when prevention and diagnosis of congenital defects is the priority, that it's missed. Mm-hmm. So, of course, what did everybody do? Okay, these are the areas that missed, let's create standards, let's create guidelines.
Yes.
So standards came out, recommendations, so much of intellect, money, society, time, standards and guidelines are out. Okay, the guidelines are out.
Yeah.
But the nitty-gritty steps that were needed to achieve that, the education,
yes,
that was lacking. But now there is no money.
Right.
All the money and resources went into, this is a problem, you define the problem, it's just in adult medicine, the heart failure guidelines, everything comes out. They say, this physician is not meeting it.
Yeah.
But you didn't start it grassroots up.
Yeah.
So I don't know if you should go this way or that way.
Yeah. So it's an excellent point, and that's why the Agency for Healthcare Research and Policy, AHCPR, I think they started in 1989, and they were charged with developing guidelines. This was seen as the solution or a major solution to the problems, variation in care. They came up with all these guidelines, they disseminated them and nothing changed. Because it was
because of this part, the community health.
Well, the guidelines, I would argue, inform, what we should be doing and maybe even processes of care, right? But ultimately, having them isn't the same as obviously getting them into practice. And so now, AHCPR changed, to the Agency for Healthcare Research and Quality, AHRQ, and their major charge now is to get, dissemination and implementation. So they're focused on getting evidence-based care into practice. They're no longer creating guidelines, but they're trying to use their limited research funding, much less than, the larger NIH budget for discovery. Well, that's my bias, but we're finally in the mode of realizing that discovery is not enough, right? We need to, there's a whole science to implementation, and education's part of that. So it's an excellent point. Guidelines aren't enough. We need to get them into practice, and that's all about the whole systems issue, right? But people need to be aware of the latest guideline, but we know that that's not enough. It's necessary, but not sufficient. It's an excellent point.
You need buy-in.
Yeah, absolutely, and that's the grassroots piece, that people need to recognize the guideline is necessary.
All the resources going to the guidelines, but
Yeah,
I think there's
yeah.
no money left for education.
Yeah.
You have to know your market first.
So I promised I'd mention some interesting ideas from adult learning. And this gets to the issue of, as experts, are we immune from, some of the biology and science of learning? Are, our brains different? And I'll comment on some of these, but the way I've begun to think about it is, no, we're really not any different. I will say if we, any expertise is, essentially a set of tools, right? And it gives us tremendous, a degree of power in terms of understanding complex things and intervening in thoughtful ways, right? That's really what we train people to be experts in. The value of that is when we hear something new that's consistent with our thoughts about and our approach, we're much more likely to recognize it and integrate it into our routine. But when we're often provided with conflicting information or something that requires a significant change in how we think or how we perform our work, our paradigm can become a barrier, right? We may not recognize it for what it is. We may struggle with it more. And so there's kind of pros and cons to expertise. But what is clear is that regardless of expertise that we have, we need to use our educational resources much more parsimoniously, much more thoughtfully. But some of the ideas that support those principles and practices that I mentioned, interaction, sequencing, needs assessment, commitment to change, those kinds of things. I mentioned that we learn something new, we forget a significant amount, but if we come back to it and we try to challenge ourselves to remember it, that action of retrieving that stored information, bumping up against what we wanted to, what the truth is, repackaging it and storing it again, that repetition. So just like, people who exercise, you break down muscle, the muscles build back stronger. The same is true for forgetting. So some degree of forgetting is good. It helps us prioritize, but it requires us to go back and forth, retrieve that stored memory, examine it, repackage it. So in our educational activities, we need to do a better job of monitoring things we've learned and forcing ourselves to, do we still understand it the way we want to? Are we still performing the way we want to? We need to do more of that in our activities. I already mentioned contextual learning, and that we should be reading, we should be engaging in activities, we should be involved in performance improvement. Any ways, different ways we can learn increases the likelihood that collectively those things will have more of an impact. And if we do just one thing, like in my training, I was told when you're done, read the major textbook in your field every 5 years, subscribe to 2 or 3 major journals, and go to grand rounds. I was told if you do those things, you'll remain current. And there's some value in those things, but I know now that that's not enough, right? It was good advice at the time, but it's not what we need for me to be part of a system that's delivering care. It's my small piece. Distributed learning spaced over time has more value than intensive one-time kinds of learning. A whole literature now on testing and self-testing, forcing ourselves to remember things. Interleaving is a concept where it applies particularly for students, is when they're studying, they mix the things they're studying. They do some review, they do some current problems, they do some advanced preparation, and they mix it up. And they're not just focused on one thing. They're focused on a subject, but they're doing different things in that subject. And that, while it makes it harder to master the individual things, in the long run, they're much more prepared for performance, because performance in context is a messy thing, right? Things are never laid out the way we learned them. So if you become facile with information in different ways, you're much more effective in practice. The notion, we've all hit this, where you hit a problem when you're working on something, whether it's an article or a study, and you walk away from it and you do something else entirely. There's something that happens in the brain subconsciously that your brain continues to work on it. And this is why, we often advise people who are learning to do regular amounts of work. If you hit a barrier, step away, do something else, come back to it, that the brain continues to function even when you're not, and there's only so much you can do to force yourself. So our educational activities, again, probably should be more longitudinal than not, but again, because there's only so much we can process at a time. And the role of regular sleep, and there's a fair amount of evidence now, certain sleep cycles or certain sleep phases encode different types of information, facts versus skills and other things. And the value, if we all actually had the luxury of sleeping regularly, there's a tremendous value of that with respect to learning. So this is toward the end here. So some of these things I've commented on, I'm aware, I've already talked a little bit about the power of paradigms. Typically, when I was Associate Dean for CME, often the comment to me in the accreditation obviously was changing and moving more in the direction of kind of quality improvement. And people would say, well, I can't do all the planning that you're requiring. We can't do all these things. We have 4 programs we're working on. We can't do that across the board. And typically people were doing more events planning than they were educational planning. And so one of the things I would ask them is, do you need to do 4 different programs, right? Could you spend more time on fewer programs and have those programs better meet the needs of your providers? So it's an option, but people will say, all this kind of stuff is fine, but it doesn't bump up to the reality that we have. Apologize here.
There's something behind you.
Thanks. Yeah, it doesn't bump up against the reality of pressures that educators and leaders have, right? And I appreciate that. And the only thing we can do is, I say start with the ideal or what the evidence base is, and do as much as you can to follow it. But recognize that there's only so much you can do. But I think we can make some changes, and we can do a better job of thinking about the evidence and the theory that supports, changes. So I'll come back to these questions, but I will mention the last slide here. This book by Benedict Carey is here, How We Learn. It does a wonderful job of describing some of the latest evidence. Similarly, Barbara Oakley has a book predominantly around math and science learning, and I recommend this and use it a lot with undergrads. But it also describes a lot of the evidence and theory around adult learning. The book by Deming, The New Economics, is an outstanding book on quality improvement, and I think if there's one book a clinician had to read, I would recommend that be it. And then this article here on the Expanded Outcomes Framework is a great article, very practical and specific about planning and assessing continuing education activities. And it goes through those steps of prioritizing and looking for performance gaps and planning up and the backwards by design concept. So it's an excellent article. But at any rate, I comment on those, but I'll come back in the remaining few minutes just to open up for some conversation, hopefully, about those 3 reflective questions. And I'll open it up. Yes, please. Oh, yeah, thank you. Yeah.
I promise I am neither smug nor cynic, though it may appear that way. there is a distinction between quality improvement and CME.
Okay.
And they're worsening, in my view.
Okay.
As if CME were a success, there would be no reason for the need for EPIC. CME is a generality. It serves a broad educational base. It doesn't address item number 6 or 7. In my judgment, quality improvement in experience is derived solely on small group interactions, examining why there was a 45% failure in a particular outcome. I'm not talking about community, though it's applicable. I'm talking about patient. And it's the team approach. We all know the knowledge. If we don't, let's go back. But why did this happen? I wish Arthur Alsis were here. We have near-miss and NIST programs here, as you know. And those have been tremendously informative. Far more than the review of update, current statistics, what's new, etc.
Okay.
So I find it CME diminishing in utility, except as the textbook.
I see.
Whereas the effort to quality improvement on a patient-directed level is strictly within a small group interactive team.
Yeah. It's an excellent point, and what I'll say is that I know that I've seen so many different, descriptions, definitions, explanations of continuing education and quality improvement, and I think the terminology is also an issue, and it's true for a lot of the intervention, a lot of the educational intervention work that we do. David Thomas, whom you know, has been very involved in a project that we're working on to standardize terminology so we can communicate better and understand interventions better. And I wouldn't disagree with you, and I'm less concerned about people's thoughts about whether continuing education is part of quality improvement or vice versa, or they're different, and more about how do we understand the practice environment, and how do we maintain and extend people who are educated and trained to provide a better and better, do a better job in their role, informed by the patient outcomes.
Yeah, but my point is that is not the solution. The solution is to use the patient, hit or non-hit, as a continuing medical education process.
I see. Okay, interesting.
It
Okay.
has to be contextual, focused on system, and has to be team and small.
Okay. And would you consider the notion of the population health perspective of patients part of that, or?
Applicable, but I haven't thought about it.
Okay. Sure. Great. No, that's an excellent comment.
So this is maybe this is related. I feel like a lot of learning I guess I can only speak for myself, but a lot of learning takes place, most productive learning. If I'm in the middle of seeing a patient, or I've seen them today, and I need to look something up in the moment or tonight,
Point of care,
or before I call them back.
Exactly.
And so, and I think almost all of us do that. Some of us do that extensively, but almost all of us do that at least to some extent.
Yeah.
So we know that it's happening, and I've got to go look, and people look in different places. We can talk about Wikipedia. People look at all sorts of good and bad places.
Yeah.
Is there a future in which something like the electronic health record, EPIC, right?
Yeah.
Since they know I'm going to look anyway.
Right.
Some brilliant 14-year-old is going to take all of that information, dump it into EPIC, so that everything I look at is linked.
You put the cursor on something, you get an explanation.
And in the moment, I can find out, am I supposed to give this lady a flu shot or not? And if I do that 10 times, I get a CME credit.
Right.
Is there a concept like that that needs to tie quality to continuing education, because the education is happening as I'm providing care, and I never have to go to a hotel again to sit.
Right. Exactly. Yeah. So I would agree. I think that's a wonderful use of technology. That would be a wonderful use of technology. I agree that should happen, and I think that should be a major way that we continue to learn, particularly given it's contextual. It's actually improving care at that moment. It's, you know, this point of care CME has tremendous value.
And it's engaging. It's
Yeah.
It's
interactive.
engaging.
The only thing I would say that would complement it, and I would recommend, is still this population perspective, because, you know, I know we're aware of what we don't know, but then there's some things we don't. When we look at the population perspective, often that gives us a different view of the care we're providing. So, but I would agree with you that that is should be a major part of how we maintain and extend our abilities. Absolutely, yeah, and very consistent with evidence on. And you can, if you forget it, you're looking it up again, right? And so it's
Point of care.
yeah, absolutely. Other comments?
Actually,
Yeah, sorry, yeah.
It's 1 o'clock. I'd like to thank Dr. Van Hill for a very engaging.
Yeah, thank you very much.